Cutaneous manifestations of rheumatology diseases. Rheumatology diseases are the autoimmune connective tissue diseases. Another term used widely is collagen vascular diseases, which should be discouraged because it doesn't exclude the inherited connective tissue diseases such as Ehlers-Danlos syndrome. These diseases are polygenic. They are caused by genetic factors. They are heterogeneous, which means they have broad spectrum of clinical manifestation, ranging from an organ disease to multisystemic, life-threatening diseases. They are overlapping in the clinical manifestation and laboratory findings. The hallmark of rheumatology diseases are the circulating autoantibodies, which are called anti-nuclear antibodies. This is the simplest figure for the mechanism of rheumatology diseases. There may be genetic factors like the major histocompatibility complex genes or the non-major histocompatibility complex genes, or in the level of the complement or other molecules. There are maybe environmental factors like drugs, infection, toxins, and sun. And there may be some physiological situation like pregnancy. So one of these factors or more can cause breakage of the immune tolerance to self-intracellular component that became self-antigens. And this affects immune activation and leads to tissue damage. And this ends in the autoimmune disease with the activation of autoreactive T and B cells that release the anti-nuclear antibodies. Next, the clinical photos illustrated slides covering the major autoimmune connective tissue diseases with skin expression. These are lupus erythematosus, dermatomyositis, scleroderma, Sjögren's syndrome, rheumatoid arthritis, and relapsing polychondritis. By end of my presentation, you should be able to recognize an autoimmune connective tissue disease by looking to the skin. With the basic knowledge of any general medical practitioner. Your ability to do that is truly an organ saving and can be life saving. Lupus erythematosus. Lupus is the Latin word for gnawing of wolf. The disease was given this name essentially by Dr. Rogerius in the 13th century. In that time, the pathogenesis of lupus erythematosus was not identified yet. And it was thought in those dark years or dark ages that the skin lesions are a result of wolf bites. And many writers thought that lupus erythematosus patients are the inspiring for the werewolf legend, which we see now in the cinema movies. Because these patients, they had some clinical presentation like the scar, the facial scars, the bleeding gum, hunger to bloody meat or bloody food, avoiding sun. All this we know now that they are part of the disease. But for some time, they were misexplained and many stories around them, which are the inspiring for the werewolf stories. The cutaneous manifestations of lupus erythematosus can be specific or non-specific. In the specific disease, there are direct intact of the circulating IgG and complement to the basement membrane. So the histopathology, if taking skin biopsy, shows the specific findings. These are called the cutaneous lupus erythematosus. Cutaneous lupus erythematosus further classified into chronic, subacute, and acute. The non-specific skin disease is a result of circulating autoantibodies, and there is no direct attacking to skin. That's why taking skin biopsy is not showing any specific histopathology findings. The skin lesions here in the non-specific skin disease are only manifested of the vasculopathy or the vasculitis part of the systemic disease. Chronic cutaneous lupus erythematosus are also called discoid lupus erythematosus. These are well-defined photosensitive discoid lesions. They are disc-like lesions in the exposed area. The head and the face and scalp are the favor part. In the early lesions, you can see dull red papules or plaques with adherent scales. Undersurface is covered with horny plaque that fill the follicles. Sometimes the horny plaques, you are able to see them easily. Sometimes you have to remove some scale to be able to see them. This is a picture of an early stage. Later on, the plaques healed centrally with atrophy and scarring depigmentation, and with peripheral telangiectasia and hyperpigmentation. So this is a figure of an old discoid lupus erythematosus lesions. Localized DLE located above the neck. They favor the scalp, the malar nasal bridge, ears, and lower lips. This is a figure also of an early DLE lesions, an erythematous plaque with the adherent scale, and if you come close up, or you can remove the scale to see the horny plaques in the follicles. Later on, this is a late or a chronic lesions with the central scarring, depigmentation, and the peripheral telangiectasia and hyperpigmentation. Of course, if these lesions are located in the scalp, it results in scarring alopecia. So patient may be coming for alopecia rather than the facial lesions, only alopecia. Then in the alopecia, you will be able to see all features of old or new lesions. Usually patients are coming with an old lesion and new lesion sometime. If these lesions are left untreated or neglected, there is a potential they go into squamous cell carcinoma. If you suspect DLA, you have to examine the ears, because the ears are one of the favor sites for DLA. And here you can see there are DLA lesions in the preauricular area, in the concha, in the helix, and the postauricular area. And in this figure, the patient have new lesions. It is pigmented here because this is a new lesions. It's pigmented because in dark skin pigmented people, the lesions are erythema not showing, but it's more pigmented. And with follicular plaque, and here, this is the late stage. This is late stage. With the depigmented scarring, and maybe inclusive you will be able to see the telangiectasia. Female to male ratio is 2:1. DLE is a cutaneous disease. There is no systemic involvement, and anti-nuclear antibody scanning is negative. However, there is the potential that these cases, DLE cases, they go into the systemic disease. That's why we need to review, re-evaluate these cases every year. In the history, do they start to have joint pain, arthralgia, fever, body ache? In the examination also, we search for new lesions under the neck, because DLE lesions below neck make them likely to go into the systemic disease, more likely to go to systemic disease. And we should repeat the anti-nuclear antibodies every year. In the level of the primary healthcare institutes, the history and examination, and there are you can do the ASR. It is also indication. If ASR is elevating, it's indication that this patient may be going into systemic disease, plus other routine investigation. If already the other systems are involved, it will be shown also. Another type of chronic cutaneous lupus erythematosus is lupus paniculitis or lupus profundus, and another common name is Kaposi-Ergang disease. There are intense inflammation leads to indurated plaques that evolve into the breast area. Usually, it's located in the upper arms, upper trunk, breast, buttocks, and thighs. 70% of lupus paniculitis patients, they have the skin disease, the discoid lesions in the superficial skin. So it is not difficult to diagnose. Clinically, you are able to diagnose that this patient is DLE plus lupus paniculitis due to the atrophy or depression. However, 30% of lupus paniculitis, they have the inflammation in the subcutaneous without any change in the upper skin. These cases need deep punch biopsy to diagnose either wide punch or elliptical biopsy to be able to see the specific histopathology findings in the subcutaneous layer. The second type of cutaneous lupus is the subacute lupus erythematosus. These are photosensitive erythematous and non-scarring. They are of two types. The most commonly is the annular and polygenic plaques that have crusted margins, and they heal with the gray to brown pigmentation, usually located on the upper trunk and the limbs. These patients, they have mild systemic affection, if any, is arthritis, and rarely they have the kidney involvement. Female to male ratio is 3:1, and diagnosis, of course, made by the serology, corresponding serology or anti-nuclear antibodies and anti-Rho, which I'm not going to go into the details. There are two figures for the lesions of subacute lupus erythematosus, two types, annular, and the other one is psoriasiform, psoriasis-like. However, these lesions, these patients, usually are more prone to go into systemic disease, and they typically have arthritis, and usually also the ASR of this patient is high, and they are more likely, psoriasiform subacute lesions, more likely, patient hair more likely to go into the systemic disease, and the confirmed diagnosis, of course, by the corresponding autoantibodies. The third type of cutaneous lupus is the acute cutaneous lupus erythematosus, or SLE. This is the severe multisystemic disease with renal affection. The cutaneous features are the second common presentation. The female to male ratio is 8:1. Usually patients is coming with the erythema of the malar area, covering the cheeks and the nasal bridge, which is called the butterfly rash. So the erythema can be mild or it can be intense with edema and with the ulceration of the lips and of the skin. There may be also a diffuse hair loss. In the hands, the erythema sparing the knuckles, and it can be severe to involve the more areas in the body, not only the exposed area. It can be also chronic and becoming more of maculopapular, lichenoid, eczema, bullous, and of course the diagnosis with the corresponding autoantibodies. Sometimes the SLE patient is coming with the discoid lesions, extensive discoid lesions. As I said before, discoid lesions below neck means this patient is likely to go to the systemic disease. If you suspect cutaneous lupus, then you will refer to the dermatologist who's going to take the skin biopsy, and it will show what we call it an interface dermatitis. The epidermal atrophy, the follicular plugging, the vacuolar degeneration of the basal layer, the lymphocytic infiltration in the dermis, mucin deposits. The second type of cutaneous manifestation of SLE is the non-specific skin disease, which result of the circulating autoantibodies, vasculopathy or vasculitis. And the most common presentation is urticaria and purpura. And in the hand, there may be an acral telangiectasia and gangrene. In the neonates, the disease is called neonatal lupus erythematosus. They have characteristic skin findings similar to those with the subacute lupus, which are the annular, mainly the annular plaques. And when they aggregate around the ears, they give the appearance of oval eye. These infants also can have DLE lesions, like this infant, and if left untreated, there are many complications, more than the scarring and depigmentation. Because these infants, they have 90% likely to go into complete heart block, congestive heart failure, multi-organ involvement, and the disease can be fatal. They need an early pacemaker placement. And majority of mothers of these infants are symptomatic lupus patients also. So as I said, your ability to recognize SLE or an autoimmune connected disease is really an organ saving and can be life-saving. Let's move to the next autoimmune connective tissue disease, dermatomyositis. This is an inflammatory myositis with characteristic cutaneous manifestation. The cutaneous manifestation in type of photosensitivity, there are such and violaceous erythema, which usually if you see one case, you will not miss the other case. And the erythema usually in the face, violaceous erythema with mild edema, usually in the face and more the cheeks and more in the upper eyelids. And the term given, heliotroplets, for describing the erythema, violaceous erythema of the upper eyelids in these patients. These lesions can present in the neck and upper chest and upper back. Usually they are becoming associated with secondary lichenoid changes with time, and the term Shawl sign is giving for lesions present in the upper back, and the term V sign is giving to describe the lesions in the neck. dermatomyositis can be associated with internal malignancy, and here usually the skin lesions precede the onset of symptoms of internal malignancy, which means dermatomyositis patient need also to re-evaluate periodically about any symptoms that can be suggest of internal malignancy and screened. If you suspect dermatomyositis, you need to examine the hands. The presence of violaceous erythematous lichen-node papules in the knuckles is clinically diagnostic. These are called the guttural papules. In the chronic disease, there may be keratoderma and fissuring of the hands, which is called mechanic hands. In juvenile onset dermatomyositis, there may be calcinosis in the dermis, subcutis, and muscle that may ulcerate, usually over the limbs. The third autoimmune connective tissue disease is scleroderma. Scleroderma is sclerosis of the skin plus minus other organs. In the skin, we look for, in the skin, it starts with early edema and end with fibrosis. And the skin is looking bounded down, which is very easy to appreciate on the hands. In the lower limbs, the bounded down is maybe difficult to appreciate, and you need to do this test, which is pinching the skin. If you are able to pinch the skin, then there is no scleroderma. In the lower limbs also, the hyperpigmentation is more appreciated. So scleroderma usually affect or start in the distal area, like face, hands, and fingers. Scleroderma can be cutaneous or systemic. Cutaneous scleroderma is also called morphea. Morphea can be localized, linear, or generalized. Other types of morphea are the frontoparietal, which also given the name incurved sapor. It can also involve the subcutis parts and called lipotrophy, and this type is called morphea profunda. In the systemic disease, it is called systemic sclerosis. There is progressive sclerosis of the skin, subcutis, and internal organs. Usually the disease starts in the ocular areas. In the face, we'll be able to see the thinning of the lips, which is called macrostomia. And there are radial perioral furrowing. And in the nose, there is beak-like sharp nose. And generally, there is reduced facial expression and lines. And patient will have difficulty in opening the mouth or opening the eyes. In the face also, there is lack of supraorbital furrowing and inability to pull the eyelid down, which is called the conjunctival sign. The patient will have difficulty in opening the mouth, and if you ask the patient to raise the tongue, he will not be able to do due to the tightening of frenulum. In examination, the fingers. In early disease, the fingers are edematous, the skin is bounded down, and the term Madonna figures given to describe the figure. There may be nail fault telangiectasia with loss of the cuticle, which is named as Hugh-Gutterin sign. And later on, there may be shortening of the index and the third finger due to the involvement of the bones and the bony resorption. And later on also, the typical rat bite, necrosis, and ulceration of the fingertips may occur. Systemic sclerosis patient are likely to have the Raynaud phenomena, which is caused by the vasoconstriction of the blood vessels of the hands. And you might be able to see one of the three zones that occur, three zones of color change that occur in Raynaud phenomena. The white zone indicate ischemia, the blue indicates cyanosis, and the red indicate the reactive hyperemia. So in normal circulation, you don't see the color change, but while in systemic sclerosis patient, due to the constriction of the small blood vessels, you might be able to see the change in the color. So white color is due to the lack of the blood flow, the blue color is due to the lack of the oxygen, and the red color due to the rebound or the blood flow returns back. So in the same patient, you may be able to see two of these color or three of them. The next autoimmune connective tissue disease is rheumatoid arthritis. This is a systemic disease which primarily manifested as arthritis, but there can be cutaneous manifestations. The cutaneous manifestation of rheumatoid arthritis are three types: rheumatoid nodules, rheumatoid vasculitis, and pyoderma gangrenosum. And usually they are manifested on the lips and more in the lower limbs. This is the figure of pyoderma gangrenosum. It starts as a violaceous papules that ulcerate fast, and in the ulcer there are undermined and overhanging ragged border. Rheumatoid nodules are the subcutaneous firm belleless nodules over the bony prominence, prearticular, and in the extensor surface of the forearms, just below the elbow, and the dorsal hands. The third type of cutaneous manifestation of rheumatoid arthritis is the rheumatoid vasculitis. And the skin lesion depend on the size of the blood vessel involved. In the small blood vessels involvement, there may be purpura. In the small to moderate, there may be livido reticularis, and medium-sized arteries if involved, there will be an ulceration. And in the chronic disease and involvement of the medium to large blood vessel, it results in the chronic leg ulceration. One of the rare cutaneous manifestation of rheumatoid arthritis is what is called the rheumatoid neutrophilic dermatitis. Here there are linear bands of interstitial granulomatous dermatitis on the right lateral portion of the trunk. Usually in these cases, after starting methotrexate for treatment, the patient may show an accelerated rheumatoid nodulosis. In the children, the disease is called juvenile rheumatoid arthritis or still disease. The cutaneous manifestation here is very similar to viral exantheme. There is transient pink macula rash over the trunk, face, arms, and legs. Next is relapsing polychondritis, which is a disease of the cartilage. Here there is an intermittent episode of inflammation of the articular and non-articular cartilage. It may end into dissolution of the cartilage of the ears, of the nose, and respiratory tract. In the ears, usually the skin is beefily red, and they are tender, and they are confined to the cartilaginous portion, while the lobule part or the remaining lobule, non-cartilage portion, is normal. And the patient also present with a saddle nose. Later on, the ear is becoming soft, sloppy, with cauliflower aspect. This is another figure of saddle nose. And finally, Sjögren syndrome. Sjögren syndrome is the disease that primarily affects the secretory glands. Female to male ratio is 9:1. There's a triad of dry mouth, dry eyes, and arthritis. Beside that, the common skin manifestation is the purpura, palpable purpura, non-palpable purpura, and pigmented purpura. Purpura is caused by extra vasated red blood cells from the capillary of the skin into the skin itself. We usually examine purpura by using a glass slide. Purpura do not blanch with a glass slide. This is how we differentiate purpura from other erythematous macules or patches. These patients, if neglected and undiagnosed, they go into lymphoma of the salivary glands, peripheral neuropathy, and hair loss. So the capsule summary from my presentation are these 2 points. Rheumatology diseases can range in severity from self-limited skin disorder to a life-threatening disease with prospect of multiple organ failure. Recognizing the cutaneous expression might lead to early diagnosis, promote treatment, and lower morbidity and mortality for the affected person. Thank you for listening.